Hi, very good morning. I'm Dr. Janak Patel, MD, General Physician. All my video lectures are mainly for educative purpose. In continuity with the previous lecture series, topics on neurology. Today we'll be discussing on one of the very interesting topic, that is acute flaccid paralysis. This is a very broad term, but it is a group of disorders which will produce flaccid paralysis, and it will be acute in onset. We'll be discussing under same heading like definition, etiology, pathophysiology, clinical features, investigations, differential diagnosis, treatment and complications. Most common cause as far as acute flaccid paralysis is concerned, we can have two big groups. One we call as infective pathophysiology, second we call as a non-infective pathophysiology. Among infective pathophysiology, the most common which is seen in children, that is poliomyelitis and other viral infections. While among the non-infective groups, one of the most common is Guillain-Barré syndrome. Now, as there is a flaccid paralysis, it is also called as acute flaccid paralysis, or also labeled as floppy groups. So there are many different ways of expressing this group of disorders. So WHO has defined acute flaccid paralysis as a rapid onset of weakness of an individual's involving extremities, upper as well as lower, often including the weakness of the muscles of respiration, and may also include the muscles which are concerned with swallowing and deglutition, and progressing to the maximum severity within 1 to 10 days. That's why it is called as an acute. The meaning of flaccid indicates the absence of upper motor neuron findings like spasticity, hyperreflexia, clonus, and plantar extensor. If any one of these findings are present, it is not pure flaccid, but there is upper motor neuron element simultaneously. Tone will be decreased markedly in flaccid, or we also use the word hypotonia as a part of flaccid, and deep tendon reflex will be reduced or absent, but sensory system, that is sensation, will not be affected. These are the some of the components of acute flaccid syndrome or acute flaccid paralysis, or also called as a floppy paralysis. Acute means rapid in onset, and that rapid in onset is the onset of paralysis less than 4 weeks, most commonly seen in a children under the age of 15, for which there is no obvious cause can be identified, or paralysis is in a person of any age in whom polio is suspected, is labeled in a group we call as acute flaccid paralysis. Flaccid means drooping without spasticity, and paralysis means loss of ability to move the different parts, particularly extremities, and may involve muscles of swallowing as well as muscles for respiration. There is one other term called as acute flaccid myelitis. When we use myelitis, means it is an inflammation of the spinal cord, and because of inflammation of spinal cord, we get flaccid weakness and that is labeled as acute flaccid myelitis. The most common organism which involves this myela, that is spinal cord, is poliomyelitis, and so that is poliovirus, and polio like other groups we call as enterovirus. So that is the most common, which is a common cause for flaccid myelitis. Also, it can be because of environmental toxins, West Nile virus, autoimmune disease, and enterovirus. Depending upon the different parts of the nervous system, there are some terminology which are being utilized. We call it anterior horn cell disorders like acute poliomyelitis and acute transverse myelitis. As far as the peripheral nerve involvement is concerned, GBS, which is post-infectious, or because of toxins of the microorganisms like diphtheria, or maybe because of porphyria. At neuromuscular junction, the most common is myasthenia crisis, botulism toxins, and ticks toxins. Among metabolic, periodic paralysis, particularly due to potassium imbalance like hypokalemic or hyperkalemic paralysis. Muscular involvement, myositis, rare, but still it is one of the cause. And among this, we have to rule out compressive pathology of spinal cord producing muscular weakness. These particular groups will be put into acute flaccid paralysis group. Among infective pathophysiology, poliovirus comes topmost on the list. And this poliovirus may be direct involvement or maybe vaccine associated poliomyelitis. So it is called VAPV. So vaccine associated poliomyelitis virus, vaccine derived poliovirus, and non-polio enterovirus. So these are some of the commonest cause of infective pathophysiology producing damage at the level of spinal cord, and that's why it is called myelitis. So acute flaccid can be divided into asymmetric and symmetrical. Among asymmetrical, the classical cause is poliomyelitis. Second classical example is a non-polio enterovirus groups. An odd group we call as a pseudo paralysis, which is mainly due to what we called as non-infective pathophysiology groups or metabolic groups. In symmetrical, Guillain-Barré syndrome comes topmost on the list. Second common is transverse myelitis, which is again very commonly non-infective group. Then botulism, which is because of the toxins of botulism organism, and acute spinal cord compression. This will be put into acute flaccid paralysis group. So it becomes a very broad group. So classification is sometimes divided into two big groups, polio versus non-polio groups. All the cases of acute flaccid paralysis should not be classified into polio and non-polio based on isolation of virus in the stool specimen, because there are many other groups which will also produce acute flaccid paralysis. So etiology wise, we can divide into peripheral neuropathy, neuromuscular junction, myelopathy, and systemic disorders. Now this particular among peripheral neuropathy, Guillain-Barré syndrome comes topmost on the list. Among anterior horn cells, it is acute anterior poliomyelitis or vaccine associated paralytic polio or vaccine associated we call poliomyelitis virus, and other neurotropic virus like enterovirus. Among muscle disorders, polymyositis, dermatomyositis, post-viral myositis, corticosteroid and blocking agents producing the involvement of the muscle, and periodic paralysis. This will be muscular groups. Among neuromuscular junction disorders, myasthenia gravis crisis, botulism, tick bite paralysis, snake bite, and organophosphorus poisoning. This will be involving myoneural junction. And among systemic disorders like porphyria, acute porphyria, acute myopathy in an ICU groups, and critical illness neuropathy. Among acute myelitis, cord compression, that is again acute cord compression. Among demyelinating disease, particularly transverse myelitis, acute disseminated encephalomyelitis, and very odd groups, multiple sclerosis. And again one another group, ischemic cord damage. So this is a very broad terminology which will be there in acute flaccid paralysis. So same thing is repeated here, anterior horn cell further divided into anterior horn cell, that is poliovirus, Japanese encephalitis virus, involvement of the dorsal root, herpes zoster, cytomegalovirus, rabies, spinal cord, acute transverse myelitis, and acute cord compression. Peripheral nerve, GBS comes topmost on the list, and then chronic inflammatory demyelinating polyneuropathy. Among neuromuscular junction, myasthenia crisis, organophosphorus poisoning, botulism, and among muscle, polymyositis, and other groups. This will be the way you divide. This is depending upon the anatomical localization. So we have already mentioned regarding infective pathophysiology, non-infective pathophysiology. Among infective, polio, non-polio enterovirus, neurovirus, Clostridium botulism, and diphtheria, Corynebacterium diphtheria. So that will be infective pathophysiology. And you can divide along motor neuron, peripheral nerve, muscles, myoneural junctions, etc. And non-infectious group, Guillain-Barré, transverse myelitis, peripheral neuropathy, muscle disorders, neuromuscular junction disorders, etc. Majority of the common causes we have already mentioned. So neuromuscular junction, muscle, critical illness neuropathy or myopathy, acute myelopathy, compressive myelopathy, spinal cord infarction, that is vascular etiology, tumors, etc. and odd conditions which can also produce acute, we call flaccid paralysis, as in case of cerebral venous thrombosis, acute stroke, hypoxic ischemic events, brainstem fossa tumors, mitochondrial disorders, etc. There is still good number of conditions may be remaining. So among spinal cord, anterior horn, roots, we have already mentioned before. So I'm skipping some of these slides. If you are interested at your leisure time, you can go through. Some person divides into tumor, encephalitis, hypokalemic periodic paralysis, pot spine, tubercular meningitis, osteomyelitis, etc. as a part of acute flaccid paralysis, but not common. You can see here in this slide the most common is Guillain-Barré, which is accounting for almost 55% of the group. 14% is hypokalemic paralysis. Myasthenia gravis crisis is accounting for 7.5. Thiamine deficiency, transverse myelitis, cord compression, and miscellaneous. So you can see these two comes topmost on the list, and then myasthenia gravis. As far as pathophysiology is concerned, it will depend upon infective and non-infective groups. Infective groups will damage the part of the central nervous system, that is either anterior horn cell or peripheral nerves, either by toxins at the level of neuromuscular junction, again by toxins, and in a metabolic group because of an imbalance in electrolytes, and involves even muscles depending upon that. So poliomyelitis is the most common. We are not going to discuss in detail regarding how the polio virus enters inside the cerebrospinal fluid and involves central nervous system. Entry is by oral route, then it multiplies in GI tract, lymphatic spread, hematological spread, and then it involves the neurons and particularly anterior horn cells neurons. So poliomyelitis mainly entry via fecal-oral route, via respiratory droplets, gut and adjacent tissue, lymph nodes. Primary viremia is usually asymptomatic, then reticuloendothelial system, secondary, and then person starts getting minor illness, and then it involves central nervous system producing classical presentation of poliomyelitis. In this minor illness, we label that as abortive polio, where almost 95% of the people recovers completely. So it involves anterior horn cell and produces the symptoms. As far as the clinical features in general is concerned, severe motor weakness, hypotonia. Because of hypotonia and motor weakness, hyporeflexia or sometimes even areflexia, early wasting, fasciculation will be present. So, person will present with, depending upon the muscle involvement, person might have pain because of little involvement of the muscle, loss of mobility, abnormal reflexes in the term of diminished reflex and absent reflex. Lack of touch sensation will not be seen in good number of flaccid paralysis unless there is an involvement of simultaneously sensory system. Bladder and bowel may be involved. If respiratory muscle is involved, like diaphragm and intercostal muscle, person might have difficulty in breathing. Because of involvement of the facial muscle, drooling, difficulty in swallowing, drooping of the face on one side. So depending upon the involvement of arm, legs, face, mouth, eyelids, etc., person will have different symptoms and signs presentation. So some of the common signs of presentation may be fever, particularly in infective pathophysiology. By and large, before a full-blown weakness, person will have upper respiratory tract symptoms and signs most commonly seen in poliomyelitis. Then person might complain of pain and numbness in the limb. Because of muscle weakness, difficulty in walking, that is gait difficulty, headache, backache, difficulty in swallowing when the muscles of swallowing are being involved or facial muscles are being involved, and person might have facial weakness. So depending upon the involvement, you will proceed with the patient. This is one of the way of proceeding in a person with acute onset of paralysis, and depending upon what you are suspecting clinically, you can proceed. So if there is paralysis within few hours to few days, we usually suspect GBS, transverse myelitis, myasthenia crisis, viral myositis, etc. If it is longer, 2 to 3 weeks, polio, Japanese encephalitis, tick bite paralysis. If it is more than 3 to 4 weeks, Lyme's, post-diphtheritic polyneuropathy, and months and years, rabies. These are the different things you can utilize, but still there can be variation in these groups also. If there is a progressive paralysis, if someone comes with maximum deficit at the onset, it is very commonly because of traumatic neuropathy. If there is a still progress over the hours and few days, poliomyelitis and Japanese B encephalitis. Further progress more than 2 to 4 weeks, GBS, varicella zoster, tick bite, and more than weeks, poliomyelitis and Lyme's disease. Depending upon the type of involvement, asymmetrical involvement will be classical in case of poliomyelitis, traumatic neuropathy, Japanese encephalitis, while symmetrical will be classical in case of GBS, transverse myelitis, botulism, and in case of rabies. This pattern you can utilize for your differential diagnosis. Sensory features will be seen in very few conditions like GBS, transverse myelitis, traumatic neuropathy, and neuropathy secondary due to varicella or rabies. Total areflexia will be very common if there is an involvement of anterior horn cell, like in case of poliomyelitis, or peripheral nerve damage, or if the person is in a spinal shock in case of a spinal cord damage. Bladder and bowel involvement is very common in transverse myelitis. Fever at the onset of paralysis, classical in case of polio and non-polio enterovirus infections. This will help you to suspect what is the probable cause of acute flaccid paralysis. Here, this is a very good chart giving you the most common causes which you come across in your everyday practice. So, polio, GBS, traumatic neuritis, and transverse myelitis. Etiology, in this you will be able to identify poliovirus either in stool or urine, or you will be able to detect polio in viremia stage even in blood. While in GBS you will be able to detect immunoglobulins, that is delayed hypersensitive immunological findings in case of GBS, while there will be history of trauma in case of traumatic neuropathy, and in transverse myelitis by and large good number of time it is idiopathic etiology, but you may be able to detect multiple viruses, different viruses which can produce transverse myelitis. The onset, if you see in polio, it is 24 to 48 hours. In GBS, it is quite fast, few hours to 10 days. Traumatic, few hours. Transverse myelitis also few hours to 4 days. Fever will be at the onset very high in case of poliomyelitis, while it is never in case of GBS. In traumatic, commonly present before, during, or after flaccid paralysis in case of traumatic neuropathy, while in case of transverse myelitis, rarely present. So in case of GBS and transverse myelitis, usually fever is not common, while it is always present at the onset in case of polio, and it may be before or during or after in case of traumatic. Flaccid paralysis usually in polio is acute and asymmetrical, mainly proximal, while in GBS it is symmetrical and distal, while in traumatic it is again asymmetrical, acute, and mainly affects one limb only, while in transverse myelitis it is symmetrical and mainly involves both lower limb. Muscle tone in case of poliomyelitis will be classical locomotor neuron, so reduce, almost tone is absent, and you will see wasting and fasciculations, as well as reflexes will be also absent in that group of muscle. While in GBS, global hypotonia. In traumatic neuropathy, reduced or absent means tone is markedly reduced in the affected limb, and you will have a bilateral lower limb hypotonia and almost reflexes will be absent. This will be the typical difference between polio, GBS, traumatic neuritis, and transverse myelitis. If you look at the deep tendon reflex in poliomyelitis, it will be decreased or absent. In GBS, totally absent. Again in traumatic neuritis, depending upon the tone, decrease or absent. While in case of a transverse myelitis, in early stage absent, and in late stage you will have hyperreflexia, because now you will start developing hypertonia. Sensory system wise, in polio, because of muscle, person will have a myalgia and backache. In GBS, person complain of tingling, numbness, hypoesthesia, cramps. In traumatic neuritis, pain will be very commonly, and person will have a disturbances of temperature. In transverse myelitis, below the level, you will have a sensory level, and below the level, you will have a total loss of all sensation. So indirectly, if you come across a classical sensory level, always suspect transverse myelitis. And if you get diminished sensation in the area where the limb is involved, and you have got the temperature disturbances, it is more in favor of traumatic neuritis. Cranial nerve involvement will be there in a bulbar poliomyelitis or bulbospinal variety. In case of GBS, if it is a Millard-Fisher syndrome, then you can have a cranial nerve involvement. In traumatic and transverse, cranial nerve is never involved. Respiratory involvement is also never present in traumatic and transverse myelitis, traumatic neuritis and transverse myelitis. While in GBS, invariably it is present in a severe cases. And in a case of a bulbar poliomyelitis or bulbospinal variety, respiratory involvement is commonly present. Autonomic involvement can be there in a case of a poliomyelitis. We get dysautonomia. In GBS also we can have frequent blood pressure alteration, sweating, temperature fluctuation, etc. While in traumatic it is rare. In case of a transverse myelitis, because of involvement of the autonomic system simultaneously, you can have a hypothermia in both lower limb. So this is very common. Among investigation in CSF, in case of a poliomyelitis, you can have a high WBC and protein will be slightly elevated. In GBS, we will have opposite, we call a cytological, albuminocytological dissociation, means protein will be elevated, cell count will be less. CSF is not involved in case of traumatic as well as transverse myelitis. Occasionally, you might have a little elevation of protein in case of a transverse myelitis. Bladder is very frequently involved in case of a transverse myelitis. In traumatic, never. In GBS, transient in the early stage. In poliomyelitis, very important, it is not, there is never involvement of bladder. So indirectly, if you get a bladder involvement and it is a persistent dysfunction, it is less likely to be polio. You should suspect more of transverse myelitis. Nerve conduction will be very useful because it will help you, particularly in case of traumatic neuritis as well as in case of a GBS. In GBS, you will have demyelinating form of a nerve conduction value, and in case of what we call as a traumatic nerve damage, you will have a axonal damage, which will be very common in this group. While in a poliomyelitis, by and large, it is an anterior horn cell damage. So nerve conduction study is good number of time normal. As well as in case of transverse myelitis also, it is normal. Once in a while, it can be abnormal, but no diagnostic value. EMG will be grossly abnormal in a poliomyelitis because there is an wasting of muscle. While in GBS, it will depend upon the recovery. Again, in case of a traumatic neuritis, it will depend upon the recovery. While in case of a transverse myelitis, by and large, EMG is usually normal. EMG will be abnormal mainly in case of a poliomyelitis because there is a rapid and early wasting of the muscle. Sequelae at the end of the 3 year is severe asymmetrical atrophy and skeletal deformity, and development of the affected limb is reduced. While in case of GBS, symmetrical atrophy of the distal muscle. In traumatic neuritis, it is a moderate atrophy of affected limb only, and there will be flaccid diplegia atrophy after a year. So there will be slow atrophy in case of transverse myelitis. These are all the differences. Same thing is mentioned here. I'll skip this slide. This is a difference between poliomyelitis, Guillain-Barré and transverse myelitis. So I'll skip this. We have already discussed those 3 groups. So this is summary of paralysis type, sensory system involvement, etiology, paralytic, symmetrical, asymmetrical, progress, sensory involvement, muscle tenderness, CSF examination, residual paralysis. Already we have discussed in previous slide. Botulism is one of the very common group which will be because of toxins produced by Clostridium botulism, which are anaerobic gram-positive organism, and the most common cause is because of exposure to the soil or honey, and it is very commonly because of foodborne, particularly preserved food containing these toxins, and very rare that wound may be contaminated by this Clostridium botulism organism. Mainly it is by the what we call is a food from tin, where the preservative is being utilized and you have got Clostridium botulism grown in that preserved food. So in that foodborne or wound botulism, respiratory system is very frequently involved, eye muscle may be involved, and you can get ptosis, diplopia, etc. You can have a involvement of the upper respiratory tract, dilated fixed pupil, you can have ataxia, hypotension, nystagmus, and decrease or absent dip tendon reflex. So these are the different groups of muscle which can be involved in case of botulism. This is one slide which tells you that if limbs and respiratory system is involved, do investigate properly. ECG, potassium, magnesium, etc. should be done. If there is an evidence of spinal cord lesion, if answer is no, then go for nerve conduction study. You suspect neuropathy. If nerve conduction study is suggestive of neuropathy, then if answer is no, then you go for anterior horn cell, and particularly we want to rule out poliomyelitis from other groups. And if the detection of polio in serum, stool or urine, you confirm the diagnosis of polio. If it is negative, then we go for neuromuscular junction involvement, and if you prove that it is myasthenia gravis or botulism, then you have to investigate for these two groups. If you are not suspecting neuromuscular junction disorders, now we go for the muscle involvement, that is myopathy, and in that myopathy you will do CPK, AST, ALT, LDH, etc. And if they are markedly elevated and you have got a urine myoglobin and serum myoglobin involvement, will suspected rhabdomyolysis. If MRI shows and you get muscle biopsy, you can confirm the diagnosis of polymyositis. If neuropathy, there is a history of trauma, then you can suspect traumatic neuropathy. And among that traumatic neuropathy, you can have acute motor axonal neuropathy. And another group which is in a traumatic neuropathy is acute infective demyelinating polyneuropathy. And this is secondary due to GBS, in which we also try to rule out other groups like porphyria, etc., HIV infections, etc. You try to rule out that in acute infective demyelinating polyneuropathy. So try to proceed depending upon that. If person is having respiratory weakness, look for potassium. If potassium is less than 2.5, you go for thyrotoxic findings, thyroid function test. And if potassium is more than 5.5, it fits with hyperkalemic periodic paralysis. If you have got thyroid function normal, then investigate for hypokalemic periodic paralysis. And if it is T3, T4 is high and TSH is markedly low, suspect thyrotoxic periodic paralysis. And if you are having hypokalemia, and look for anion gap. If it is a normal anion gap metabolic acidosis, then you can look for urinary anion gap positive. Then it is distal tubular, renal tubular acidosis. And if it is urinary anion gap is negative, then you can suspect diarrhea or idiopathic groups. This is one nice slide where you can differentiate some of this group where got a limb with respiratory weakness. If you look at the facial palsy, unilateral facial palsy, you go for this workup. If you have got no facial palsy is there, it is not unilateral, it is bilateral, you go for this. If it is monoplegia and history of recent trauma, this is the investigations. And if there is monoplegia and history of trauma is yes, this is the investigation. If history of trauma is no, you go for this investigation. So there are many different ways and means of proceeding with flaccid paralysis. Here, if fever is present, yes, you go for this too. If answer is no and it is symmetrical, then go for this. If answer is no, go for this traumatic neuropathy. If answer is yes, so fever, answer no, symmetrical, answer yes, then go for GBS, post idiopathic polyneuropathy, etc. So this is the way you approach, means what way, but clinically good history and good examination will give you a good idea. So I'm skipping all these things. This is again same. You go for symptomatology, examination, proper examination, and then you go for depending upon the muscle weakness. So demonstrable lower limb, motor weakness, preserved, glove and stocking type, etc. And then you go for muscle disorders, peripheral nerve disorder, spinal cord disorders, and further. So as you proceed with the investigations, clinical examination, and finally investigations. Among investigation, the most common investigation one is nerve conduction study, which will tell you regarding a peripheral nerve involvement, what type of, whether it is demyelinating, axonal neuropathy, etc. EMG will give you an idea regarding a muscle involvement, that is myopathic groups. CSF examination will be very useful in case of GBS and CNS infections. MRI will be also useful in finding out the spinal cord involvement or nerve root involvement or plexus involvement. CPK, if it is markedly elevated, it will be very classical in case of myositis and dermatomyositis as well as myopathic groups. Then single muscle or single muscle fiber EMG will be very useful in case of a myasthenia gravis. Blood count not of much importance, but maybe of some importance in a chronic systemic illness. Eosinophil count will be elevated in case of vasculitis neuropathy. ESR may be elevated in autoimmune disorder as well as infective pathophysiology. We have already mentioned CPK will be markedly elevated in muscle disorders. Blood urea and creatinine will be elevated because of involvement of the kidney secondary due to myoglobinuria, rhabdomyolysis. Electrolytes, particularly potassium, will be very useful in case of identifying hypokalemic periodic paralysis and hyperkalemic periodic paralysis. Thyroid hormone to rule out thyroid related myopathy. And collagen disorder studies will help you to identify polymyositis and vasculitis neuropathy, etc. In general, the management will depend upon two most important goals, that is stabilize the patient, particularly regarding the respiratory, that is ventilation. Person may be benefited by non-invasive or invasive depending upon the severity of involvement. And history and physical examination will be very useful to suspect the clinical conditions, and then by a appropriate investigation you will come to the perfect diagnosis of acute flaccid paralysis, and then you can decide regarding the management. So child will require an ICU admission if there is a respiratory insufficiency or vasomotor insufficiency, or it is very rapidly progressive like in case of a GBS. or if a person has got a bulbar symptoms, particularly in a GBS and in case of a poliomyelitis, quite common, or some groups particularly suspected poisoning like botulism. Acute severe systemic illness may also require an ICU admission because they rapidly go into complications. Some of the conditions will produce lot of complications depending upon poliomyelitis. Say poliomyelitis, very commonly respiratory involvement will be very common, death are quite common, and chronic limb deformities, wasting, atrophy, etc. will be very common. In Guillain-Barré, respiratory autonomic crisis, residual weakness, and sometimes they even mortality. While in case of a transverse myelitis, residual defects like bladder and bowel dysfunctions is more common with transverse myelitis. It is never with poliomyelitis. Guillain-Barré in an early stage it is there, but late stage person recovers. So bladder and bowel involvement is more common and persists even in person after recovery, that is in transverse myelitis, and you will have a weakness as well as atrophy in lower extremities. So this is in general, in short, the presentation. So in a poliomyelitis, respiratory limb atrophy and death is very common. In GBS, respiratory autonomic and residual weakness. Transverse myelitis, bladder and bowel involvement and dysfunctions, particularly weakness, atrophy, will be in lower limbs, both lower limbs. So in general, I've tried to cover up the common conditions which can produce acute flaccid weakness. So at the end of this lecture, I thank you all for taking out time. I know that your time is valuable, and I also appreciate that you have spent some of the time with me. I feel this will be helpful to you in your everyday practice. Maybe ask in your oral exams, or sometime you may be given some topic from this in your theory. If you like this lecture, don't forget to press button like, subscribe, press bell icon, and you can share with your friends. And if you feel your good suggestion, most welcome. See you in next lecture.